Hello, I am Gerardo Rodriguez Diez. I am EP from Mexico City. My task today is talk to you about cryoballoon ablation in atrial fibrillation. I would like to thank Dr. Luis Carlos Sáenz, President of LAHRS, and Dr. Ulises Rogel, President of SOMEC, for their kind invitation. We'll start to mention the global prevalence of atrial fibrillation. In Mexico is not as high as United States or Canada or Europe or even in South America, Brazil or Argentina. But we have enough cases now. This is the most recent algorithm to treat atrial fibrillation is the CC2ABC, in which we need to confirm, characterize, and then treat with anticoagulation, with symptom control, perhaps with early recovery of sinus rhythm and control comorbidities. There is relevance in recovery sinus rhythm because if we start to treat this illness early, we could delay the progression to advanced forms of atrial fibrillation like persistent or permanent, which are more difficult to treat and recover sinus rhythm. The study affirmed shows that if we maintain the patients in sinus rhythm and with good anticoagulation, we could impact in the outcome of atrial fibrillation. And in this recent study with early rhythm control therapy with antiarrhythmics or even with atrial fibrillation ablation, with this strategy we could improve the primary outcome of the patients with death, which is death from cardiovascular causes, stroke, hospitalization, or worsening of heart failure. What we need to do is only to isolate the pulmonary veins, because it has been shown in the STAR-AF study from persistent atrial fibrillation that if we use the arm with only pulmonary vein isolation, not plus CAFIs or with additional lines, we could have more patients freedom of atrial fibrillation in long term, only with pulmonary vein isolation. And to achieve this, we could use two techniques. The gold standard it was radiofrequency ablation, point by point, isolated the pulmonary veins, and cryoballoon ablation recently developed. With radiofrequency, we need to be very precise in the length of the points to perform the isolation to achieve it in the first pass. With cryoballoon, we use one or two therapies in the ostium of the pulmonary veins. In this ostium, we could also ablate the ganglion plexi and the left posterior wall, which are involved in the initiation or trigger and sustain the atrial fibrillation. We also could ablate more than 50 or 70% of the left atrial pulmonary, the left atrial wall in the left atrium. So that's why my first choice of treatment for AF is cryoballoon ablation. In the STOP AF study, it has been shown that cryoballoon was better to antiarrhythmic drugs, another than amiodarone or dofetilida, but with 70% patients in sinus rhythm at 1 year follow-up. Recently, the STOP AF FIRST presented in the European Congress of Cardiology with cryoballoon ablation versus antiarrhythmic drugs in naive patients without receiving previously treatment. We have here 75% patients free of atrial fibrillation at 12 months follow-up compared with 45% with antiarrhythmic drugs. So cryoballoon ablation has some advantages because we could have an effectively circumferential lesion around the pulmonary veins. This homogeneous lesion could be achieved with 1 or 2 therapies with 180 to 240 seconds. And that's why we have a shorter learning curve compared with radiofrequency, and that makes us less operator dependence in the procedure. So cryoballoon ablation had reliable and reproducible results in the short and long-term follow-up anywhere in the world, with some kind of better safety profile, mainly with less pericardial effusion. In this meta-analysis, cryoballoon versus radiofrequency, it has been shown that we have less cardiac tamponade with cryoballoon ablation. How I make the procedure? Well, I always try to use eyes to guide not only the transeptal puncture, but also be more efficient in the pulmonary vein occlusion. I use a decapolar catheter in the coronary sinus, and with eyes, I select the right spot that I want to perform the transeptal, the puncture. Ideally, watching the left pulmonary veins across the septum, then push firmly, not so hard, and then cross the septum. It's very important when we cross the septum, look out for the presence of thrombus. This thrombus could be stuck in the sheet or in the wire. When it happens, we need to inject heparin and wait till the thrombus disappear. Then we use fluoroscopy and contrast medium to seal the pulmonary vein completely and watch the disappearance of the electrograms inside the pulmonary veins. This is a video in which we could see the electrograms in the pulmonary vein starting the therapy, and in less than 30 seconds we could watch the disappearance of these electrograms, resulting in a success therapy. We could also use eyes to seal the pulmonary vein and to corroborate this seal without leaking of blood. In this image, we see the balloon occluding the left superior pulmonary vein, and then we saw flow from the left inferior pulmonary vein. But the targeting here is the left superior pulmonary vein and is totally sealed. And we could watch post-ablation that the extension of the lesion is not only in the ostium of the pulmonary veins, but also in the left posterior wall of the left atrium. The results are the same worldwide. This is Europe. In 2 high-volume centers in Germany, 70% patients with paroxysmal AF and 40% patients with persistent AF. With repeat procedures, we could reach 80% patients free of atrial fibrillation. This is a 3 years follow-up, and these results are the same that in Latin America. This is a paper in press in several centers with high volume in Latin America, obtaining 88% patients free of atrial fibrillation at 1 year follow-up, and 73% patients with persistent atrial fibrillation. And these results are the same in Mexico. 79% patients free of atrial fibrillation and 1 year follow-up. What happened with redo interventions? We know that radiofrequency has more reconnections of the pulmonary veins than cryoablation has. If we use first cryoablation and then in redo we map in 3D, that's what I do, it's easier to detect where is the gap between the ablation and then put some spots to completely isolate again the pulmonary veins. It is very important to manage the risk factors to avoid the recurrence after cryoballoon ablation or after ablation. And it is important to control hypertension, the physical activity, alcohol, obesity, etc. So in conclusion, atrial fibrillation is a complex and multifactorial disease, very hard to treat. We must pursue early sinus rhythm as soon as we detect atrial fibrillation. The invasive treatment is the most powerful tool in long-term follow-up to maintain sinus rhythm. Depends on the operator which technique could use, cryoballoon or radiofrequency. Both are very effective. For me, cryoballoon ablation has a good efficacy and therapy and safer profile than radiofrequency with reproducible results anywhere in the world. The same in Europe, Latin America, United States. Let me finish with this image that is an amphibious called axolot or ajolote in Spanish. It's a dangerous species which live in Xochimilco Lake in Mexico City. This amphibious is very complex, so is the left atrium. It's a very complex structure, and that's why it's very hard to treat atrial fibrillation. Thank you very much.